Apolkar and the ISTS leadership for this invitation. I'm following up on two great talks on focused and bilateral exploration for primary hyperparathyroidism. I'm asked to discuss this persistent and recurrent hyperparathyroidism. I'll restrict to primary and not delve into secondary and tertiary hyperparathyroidism. Well, parathyroid surgery has been sadly made up to be a very simple, straightforward procedure. But those who understand Hindi and Urdu, ये इश्क नहीं आसा, बस इतना समझ लीजिए, ये आग का दरिया है और डूब कर जाना है. The beauty and the devil lies in the details. And as Professor De Cruz said, maybe 80 to 90% patients can be cured by majority, but the commitment for us lies in curing 100% or near 100%. Anyhow, so when patients have been operated, even by good surgeons, experienced surgeons, roughly about 10% of them will come back with recurrence or have persistent disease. And this is how these patients would have to be taken care. I'll start by giving you some definitions and then a plan for managing such patients. And the most critical two parts or two components of decision making are when to operate and what is the procedure to follow. And then, time permitting, I'll discuss what has been the newer developments. So this has been done earlier, so I'll skip that. You can have hypercalcemia recurring or persisting after an initial surgery or recurring within 6 months. That's persistent disease. And if it recurs after 6 months of normocalcemia following the first surgery, that's recurrent hyperparathyroidism. Why is it important to discuss recurrent hyperparathyroidism as a standalone topic? Well, we know that the first time surgery is the best opportunity to cure these patients. The second operation has lower success rates, has higher complication rates, and high rates of non-therapeutic or negative explorations. And the cost of re-exploration is certainly higher. Multiple data sets from various parts of the world, they reveal that the parathyroid success rate, surgery success rate, drops down to about 85%, even in hands of experienced surgeon, compared to more than 95% success rates, and with a 6-fold increase in vocal cord paralysis and other complications. So this is not certainly something which you would desire to do, but unfortunately we'll have to continue doing in some patients. When dealing with such patients, the two most important considerations to begin with are to revisit the diagnosis to ascertain that indeed this was a patient of primary hyperparathyroidism, and the current manifestations after a failed operation, are they severe enough to warrant a reoperation? So it can be, we can see these patients in both the settings, sporadic and familial, with somewhat different kind of case specifics. In patients with sporadic, who majority would have a single gland disease, yet have a persistent or recurrent disease, we have to look for a possible missed adenomas, or in selectively or rare cases, missed multi-gland disease. In familial disease, however, we are almost always looking at a missed multi-gland disease, either that was not considered in the first place, or one or more glands were missed, or a supernumerary gland was missed initially. So, while dealing with this scenario, one has to be aware of what are the various reasons or causes why the first surgery has failed. Unfortunately, a vast majority, close to 2/3 of all such patients, have resulted from a missed adenoma at the utopic or the correct or natural location. Another 1/3 of them are because of missed multi-gland disease or undertreated hyperplasia or multi-gland disease. Ectopic parathyroid glands, we were discussing this, accounts for truly ectopic glands, account for less than 1% of all persistent diseases. Roughly about 3% are because of either recurrent or persistent carcinomas, and parathyroidomatosis fortunately are rare, and I'll discuss it further. But a common factor to all these issues is inadequate experience of the surgeon, perhaps the one which causes recurrence in majority. So managing these patients starts from reconfirming the diagnosis, the biochemical diagnosis, and then evaluating for a possible reoperation or need for possible reoperation. If indeed there's a need, we then decide what's the perfect or ideal timing for it. And then comes the most important part, which is preoperative localization, which is mandatory in patients where you are undertaking a reoperative surgery. Which of these preoperative localization studies to do, I'll discuss a little further. There would be rare circumstances in which, in patients where you would like to reoperate, even though the preoperative localization studies have not given you concordant or ideal results. Which approach to follow? A standard midline one, a lateral approach, superior, inferior, which adjuncts intraoperative neuromonitoring, IPTH, frozen sections to use, and then finally, most importantly, there would be patients where you'll be humbled. Even with all your equipment and help, you would have to decide not to treat them any further. So this is one lesson we all must learn, when to stop. So not all patients who have mild elevation of PTH following surgery have a recurrent or persistent disease. This scenario can occur with either normal calcium levels or high normal calcium levels in patients who are vitamin D deficient, who have mild renal failure, those who have now started to have a hyperfunction of previously suppressed parathyroid glands and unrecognized FHH and certain other familial disorders. Localization is the key, as I said earlier, and what we must try to do is to have one functional, one anatomical imaging procedure, and have a concordant imaging before reoperating these patients. Which is the best combination is anybody's guess, but the success rates of surgery in patients who have concordant imaging studies is more than 95%, even in reoperative setting with this kind of preoperative imaging. However, without preoperative localization, it drops down to about 60%. So, in the current guidelines, preoperative imaging and successfully localizing the parathyroid, the culprit parathyroid gland, has been shown or has been written as mandatory with a strong recommendation. This table only shows what has been discussed earlier. I'll only like to say that all of these imaging studies are operator dependent. No two system EVs are alike. The same patient may have a negative system EV scan in one institution and added with SPECT CT and dual phase studies, it may be a successful imaging. PET scans are useful in selected patients. We often use carbon-11 methionine in reoperative settings, and then rarely we can use in invasive procedures like venous sampling. There can be patients who deserve to be treated medically, non-surgically. Either they are too high surgical risk or they have mild disease which doesn't deserve to be reoperated, and cinacalcet is the current drug of choice which we can use as a bridge therapy, or even for patients who have hypercalcemia which cannot be cured, like persistent carcinomas. The key decision to make is when to operate. All patients who have symptomatic or complicated hyperparathyroidism, and even those who are asymptomatic but have manifestations like osteoporosis, and you have been able to localize the gland well before the second surgery. And the aim at the second surgery is to achieve a permanent cure, but rarely in certain selected patients, debulking to reduce the pathological tissue like in uncured parathyroid carcinoma. And this should start with reviewing all the previous information that you can derive for that patient, starting with the previous biochemistry, imaging, surgical data, the pathology. Also, we must assess their vocal cord function, understand the embryology of parathyroid and what may be applicable to that individual patient, decide which approach you might have to take, and then, as I said earlier, decide when to stop. Preoperative laryngeal assessment is mandatory in these patients. And first, let me go to the scenario where you are dealing with a possible single gland, a missed single gland. How do we approach these patients? After biochemical confirmation of the diagnosis, establishing the need for reoperation, reviewing all the previous operation and pathology records, you do a first set of imaging in form of a high resolution ultrasonography, ideally a surgeon performed ultrasonography along with a system EB. And I very strongly believe in SPECT CT, dual phase system EB scan. If they are concordant, then you go ahead, explore the neck, remove the culprit gland. If they are discordant, then go to the next step of imaging. A 4D CT is our next go-to imaging. Besides 4D CT, one may undertake various other things, then explore the patient, use appropriate intraoperative tools, including the intraoperative ultrasound, IUPTH, and frozen section histology to achieve good results. Now, this is a case, this patient, very young patient with bone deformities, underwent a robotic retroauricular parathyroidectomy elsewhere, which was converted to open exploration. Remained asymptomatic for 2 years, came back with recurrence, and at that stage referred to us. We reconfirmed the diagnosis, we localized on imaging. Ultrasound was non-contributory, but NIBI showed mild focal uptake in the left lower pole, and we also did a choline PET CT, which was confirmatory, and a 4D CT, which showed 2 nodular lesions adjacent to the left lower pole. So the decision for reoperation was there, a very young patient with recurrent hyperparathyroidism, and we suspected parathyromatosis, essentially because I could speak to the surgeon who did the first surgery, and he was forthcoming in saying that they may have ruptured the capsule at the first surgery. So it gave me a clue that we may be dealing with a parathyromatosis. We reviewed all the previous data, and in this case I was lucky because I could speak to the surgeon and get a lot of information. We planned all the adjuncts for the intraoperative aid. We found multiple brown lesions like parathyromatosis between the lower pole of the left lobe and the nominate vein. We did the appropriate procedure as I will show you, and patient has been recurrence free for 4 years now. And this is from the operating records of the patient. We found multiple brown colored lesions like parathyromatosis noted in the region between lower pole of the left lobe and the nominate vein. We excised it en bloc like we would do a hemicentral compartment lymph nodal dissection. And then of course the IUPTH dropped to more than 50%, and the frozen section confirmed multiple parathyroid lesions, which eventually on peripheral section histology was reported as parathyromatosis. Another patient of failed bilateral neck exploration elsewhere, we found a superior mediastinal parathyroid adenoma. This patient was a very high surgical risk because of poor lungs. We would have ideally liked to do a video-assisted thoracoscopic excision. However, it was not appropriate for single lung ventilation, so we used a partial sternotomy and parathyroidectomy, and the patient is cured. Another patient with a failed endoscopic parathyroidectomy elsewhere, a young patient again, and here in this patient, the imaging was concordant, and we decided in consultation with our nuclear medicine colleagues that we would use the location predicted on CT was rather unusual, so we preferred using a radio-guided parathyroidectomy. We found the tumor at the root of the carotid, and so indeed our decision to undertake something unusual was, but that this could be done transcervically and did not require a sternotomy. And this is just the operating notes showing the tumor location. Another patient, now looking at scenario where you are expecting multi-gland disease. When would this be? You're dealing with a patient with MEN1 where the probability of recurrence and persistent disease is very high. According to some, it's just a matter of time when you would see a recurrence after initial parathyroidectomy, and rarely in MEN2 patients too, as well as in patients who have sporadic multi-gland disease, primary hyperplasia of the gland, not necessarily secondary, and some patients who would have double adenomas or multiple adenomas. Here is an example. This 68-year-old lady was referred from Calcutta who had 2 prior explorations in that city, once by a surgical oncologist, another procedure performed by a ENT surgeon. Two parathyroid adenomas, supposedly parathyroid adenomas, have been removed earlier, unfortunately leaving her with a paralyzed vocal cord. We reconfirmed the diagnosis biochemically. There were plenty of indication for reoperation. Patient had osteoporosis, vertebral fracture, multiple bilateral renal stones, unfortunately also had left vocal cord palsy. We tried reviewing the pathology and surgery data from that city, only could do it to a limited extent. We undertook MEB and ultrasonography, which were not confirmatory, and then 4D CT showed two possible lesions lateral in the neck on the right side, and then we undertook jugular venous sampling, and as you can, and as you can see, there was a lateralization to the right side, and the upper part of the jugular vein was showing much higher PTH concentration. We indeed found two culprit glands there. Before the operation, that's to show the 4D CT picture. A surgeon performed ultrasound on table, showed these two lesions medial to the carotid vessels, carotid sheath structures. With intraoperative neuromonitoring, we excised the previous scar, explored through a lateral approach, and we found two culprit glands. The inferior gland was unfortunately reported as a parathyroid carcinoma. Fortunately, this patient is cured for about 4.5 years now. So the recent or not so recent guideline brought out combinedly by the American Head and Neck Society and the British Association of Endocrine and Thyroid Surgeons kind of provides all these guidances that I've talked about so far. Bilateral neck exploration is the way to go in majority of these patients who have persistent or recurrent hyperparathyroidism. However, one can selectively choose patients to undergo focused or minimal invasive procedure, but that should be an exception, not the rule. Bilateral neck exploration as a whole in general, and more so in patients who have persistent or recurrent hyperparathyroidism, is based on an embryological anatomy and not just anatomy, local anatomy of that patient. We must keep in mind all the ectopic locations, including mediastinal, intrathyroidal, and all these other locations. And as much as possible, we should try and approach the parathyroid glands through an undissected virgin planes, and my preference is usually lateral approach because majority of patients have had a central approach earlier. Aim is to try to identify all the 4 parathyroid glands or the ones which were except for those which were removed earlier. I'll skip the steps of parathyroid exploration or bilateral exploration, but as I said, and it's worth re-emphasizing that you must know your anatomy and embryology before you undertake this kind of procedure. And few pearls that I would like to share. Parathyroid glands are very delicate. The capsule can be torn easily. So what you do is do not ever hold the parathyroid gland or its capsule. You hold the periparathyroidal fat or soft tissue and not the tumor itself or the gland itself, because there is always a risk of seeding. Parathyroid tissue is highly engraftable. That is the property we use for autotransplantation of the parathyroid glands, and a hypercellular parathyroid is even more engraftable. So we must not we must avoid any seeding or dismembering of the parathyroid gland. How do we recognize an abnormal parathyroid gland? From its size, the contour, which is a bulging ovoid kind of tumor, or hyperplastic gland. The darker brown, the London tan kind of color, it is less compressible compared to a normal parathyroid gland, and from its large pedicle. But the bottom line, which cannot be written in a slide, is the parathyroid eye. I must recollect what John Dockman said long ago. Sadly, I may be offending some of the nuclear medicine physicians in the audience if they are here, that parathyroid localization is entirely dependent on the experience of the surgeon. Everything else is secondary, and the experienced parathyroid eye still cannot be replaced even today. A secondary exploration step is always to be remembered. You may not find the parathyroid glands in the location you expect them to be. In this scenario, you would need to examine the thymus, palpate the esophageal space, retropharyngeal space, mobilize the superior thyroid pole, explore the carotid sheath, and then locate intrathyroidally if you can't find it anywhere. IOPTH is mandatory in this scenario, while it may be optional in patients undergoing first-time surgery. FNA PTH for PTH washouts can be recommended and used selectively, and INM is again recommended highly. There are other adjuncts that have been discussed, NIRAF and ICG. So, as a take-home, I would say secondary hyperparathyroidism patients, recurrent or persistent hyperparathyroidism patients are not to be taken lightly. We must revisit the diagnosis, starting with the biochemical confirmation, image the patients appropriately to identify the culprit glands or locate them, and then undertake bilateral neck exploration in patients who deserve to be operated. There would be anecdotal patients who can be managed conservatively, non-operatively, or can be simply observed. And while doing this kind of bilateral neck exploration, you must have at your disposal at least some intraoperative aids, including intraoperative neuromonitoring, intraoperative PTH estimations, and frozen section histology to get successful results. Thank you very much.
One question. As an intraoperative juncture, can video guided surgery be done by using
Yes, it can be done. And I would like to add that this is not a panacea. Radio guidance is not a panacea. It's not always possible to locate maybe concentrating tumor, because there's so much background noise as well. So that's why it's not very popular procedure to perform.
When to go for frozen section? Sir,
Yes.
when to go for frozen section? In every case, or if you have a doubt that a PTH is not reducing or something?
Well, I think we can select patients where you are in doubt, but I have a very low threshold for frozen section, because confusing a lymph node or a fat lobule for a tumor is not very difficult. So as I said, we perform frozen section very frequently. Thank you.